So, a very good day to one and all. So, today we'll be discussing about a very important topic, which is not only important from the medical point of view, but very extremely important from the surgical point of view as well. Because this is a condition which is extremely common among people of all age groups. Right from the youngest person in the family to the oldest person in the family is very much susceptible to this particular condition called burns. So, the incidence of burns varies from age to age as well as from area to area. In the United Kingdom, it has an incidence of there are about 1.75 lakh cases of burns which are documented every year. And out of these, 13,000 people are admitted every year. Out of these 13,000 people, 1,000 of them require fluid resuscitation, and more than 50% of these people or patients who require fluid resuscitation are under 16 years of age. So, children most commonly sustain burns because of either scalds sustained by hot water, bathing water, or by inadvertent touching of kettles, pans, etc. Adolescence, that is the age at which experimentation occurs, you find that the most common cause of burns are basically matches and flammable liquids in adolescence. In adults, flame burns are again very common. Along with it are common electric and chemical burns. Two quite rare causes of burns are cold and radiation. So what is the pathophysiology behind burns? So as we all know, the most common organ affected by burns is the skin. Along with it is the airway and lungs. So injury to the airway and lungs is particularly common in those burns which are sustained by individuals who are trapped in a burning or in a burning room or a burning house. So here there is physical burn to the nose, mouth, tongue, palate, larynx because of the hot gases that are present within the room. So because of this burn or because of these hot gases, the lining epithelium of these sensitive mucosa line structures like the nose or the throat, etc., tends to swell up. Because of this, it leads on to airway obstruction, and airway obstruction would result in stridor and distress. As this descends down, you find that as the hot gas descends down, the respiratory epithelium, again, as it comes down into the respiratory tract, the respiratory epithelium also swells up. Once it swells up, you find that it slowly detaches itself from the bronchial tree. And as it detaches itself from the bronchial tree, these get devitalized and form casts within the airway, and this can cause an airway obstruction as well. A very important phenomenon which occurs especially in people who are trapped inside a burning house or a burning room or a burning car, whatever, is metabolic poisoning. You are all familiar with the terminology of carbon monoxide poisoning. So carbon monoxide is a product of incomplete combustion. So it has about 240 times more affinity to hemoglobin compared to oxygen. And you find that when the serum carbon monoxide level is more than 10%, it is extremely dangerous and the person will require oxygen treatment for more than 24 hours. And once this level reaches 60%, death will occur. Hydrogen cyanide, which is also an important component which is an important component of gases which are produced during burning or during combustion, it is known to cause acidosis as it interferes with mitochondrial respiration. Now, so like I said earlier, in our earlier chapters, we had discussed about how injury incites an inflammatory response. So burns is also an injury. So burnt skin, which is an injured area in the body, it incites an inflammatory cascade. So this is initiated by the stimulation of pain fibers and the alteration of proteins by the heat. So this altered protein, particularly the H1 factor activation, is known to cause a cascade of events resulting in activation of the kallikrein pathway. Complement-induced degranulation of mast cells is also very common, and these complements coat proteins which have been denatured by heat, and this denatured proteins which are coated by complements act as chemotactic factors or attract neutrophils and incite an inflammatory response resulting in the production of oxygen-derived free radicals and proteases. This inflammatory response, one of the most important markers would be a tumor necrosis factor alpha along with interleukin 1 and interleukin 6. So these inflammatory markers and cytokines will increase the vascular permeability locally, causing extravasation of fluid and proteins from the vascular compartment into the extravascular compartment. Because these proteins come from the vascular to the extravascular compartment, there's loss of proteins resulting in a decrease in oncotic pressure on the vascular side and an increase in oncotic pressure on the extravascular aspect. This again pulls out more fluid from the intravascular region. So the overall effect is that there is net movement of fluid and solutes and proteins from the intravascular to the extravascular compartment. So this occurs within the first 36 hours after the injury. Any person who has sustained 10 to 15% of body surface area burns are likely to go into circulatory shock. And more than 20% burns if the person is sustained, then vessels which are removed from the area of injury also tend to get involved